In this episode, Dr. Coffee Brown introduces the topic of sleep medicine and answers the questions. What are sleep doctors? Why do we need sleep? His guest is Dr. Lee Brown, electrical engineering MD, tenured professor of internal medicine, professor of pediatrics in the School of Medicine, and professor of electrical and computer engineering. If you or someone you know have difficulty sleeping or feeling energized throughout the day, then the answers are likely to be found in this informative discussion. Join Dr. Coffee Brown to discuss what's new in health and medicine. Dr. Brown and his guests explore the latest research and technology in health and medicine and help us understand how it affects our lives. Then, they provide takeaways and steps we can take to improve our own health in the future. We're glad you're here to take part in the conversation. Thanks for joining us today. And now, back to our host, Dr. Coffee Brown.
Thank you, Shelley. My name is Dr. Coffee Brown, and this is the first of what we hope will be a series of podcasts on medical and scientific topics. And for our first guest, we could not have a better choice because Dr. Lee Brown, no relationship of mine, Mom told me to say that, is a very good friend of mine from the University of New Mexico, somebody I've had the pleasure of serving on several committees with. And he's an example of just how extraordinary some of these speakers can be. His first degree is in electrical engineering. Then he went ahead and got his MD and went on to get board certified in internal medicine, then pulmonary medicine, and then sleep medicine. Of his many areas of expertise, tonight we're going to be talking about sleep medicine, which I think is a lot of people think a lot about quality of sleep and importance of sleep and things like that. I'm intrigued by some questions about it. And because, Lee, you have so many areas of expertise, I'm hoping this will not be our last visit with you. All that said, sleep medicine, why is that even a thing? What is a sleep doctor? Who goes to see you? Why does that exist as a specialty?
Well, we spend, or optimally, we spend about a quarter to a third of our lives sleeping. It's a vegetative process like thirst and hunger. That is, if you don't get enough food, you get hungry. If you don't get enough liquid, you get thirsty. Well, if you don't get enough sleep, you get sleepy. And there are a variety of consequences to not getting enough sleep that we can get into. But sleep is just as important as eating and drinking and lots of other things that we do that our body makes us do.
What if I don't sleep? What'll happen to me?
So sleep deprivation has multiple effects. And it's not just that you get a short night's sleep, not as much sleep as your body requires, but it's also if you get interrupted during the night in your sleep, and therefore your sleep is not continuous and what we call consolidated. So, and also, even if you short yourself in sleep by an hour or two or three during weekdays when you work, and you try to catch up on it on the weekends, you are still sleep deprived technically. And there are lots of consequences of that. The consequences are pretty profound. It certainly affects cognition, so it affects memory. And we can talk about what sleep has to do with memory, if you'd like. It has to do with attention span. It has to do with reaction time. There are tests on computers that we apply to individuals in research who we sleep deprive, and we can show that their reaction time is poor. There are driving simulation programs that do much the same thing. One of them was called Steer Clear because It had to do with the sudden appearance of a cow in your path on a simulated road, and it detected how long it took you to notice the cow and not run into it. Steer, of course, was spelled S-T-E-E-R. I thought it was rather clever. In addition, of great interest to me as a physician, and having spent many overnight shifts going without sleep for very long periods of time, sleep has been shown, or sleep lack has been shown to affect moral judgment. So that is tested by computer programs that set before the subject a moral or ethical question. The most common one is whether to run a red light or not, or to judge whether when it turns yellow, do you have enough time to get through before it turns red. And sleep-deprived people are going to barrel ahead no matter what, but people who have adequate sleep are more likely to make a more reasoned decision, and one that is morally and ethically sound.
I think I got into a car accident once as a consequence of a micro nap. Actually, I was working a lot of night shifts and so forth, had a long drive to get home. Two functions of sleep that I'm aware of are recharging of adenosine, putting phosphate on adenosine. Remember, this is for a lay audience, so I'm going to say recharging literally the cellular batteries. And another is, judging from some recent rat experiments, the consolidation of memory. And the effects that you just described mostly seem to relate to the ATP, speed of reaction, ability to handle challenging cognitive tasks. Are those the functions we should think about, or are there more that we should be thinking about?
Well, I covered some of them. There are others. You do have it correct that one of the main functions of sleep has to do with what we call the recovery of central nervous system neurons that undergo a reversible change during wakefulness that accumulates during the time that you're awake. And you mentioned one of them, adenosine, which has been shown if you micropipette small amounts of adenosine into certain areas of the brain, you can make a rat sleepy, for instance. So it's a sleepy inducing neurotransmitter. And that's actually how your namesake works, coffee. Coffee is a competitive antagonist of adenosine at its receptor. And so it prevents adenosine in the brain from inducing so much sleepiness. But there are other chemicals that accumulate, interleukin-1 beta, glutathione, and the most recent and most interesting literature to me has to do with the accumulation of beta amyloid in the brain, and how during sleep beta amyloid is cleared from the brain. There's a whole system called the glymphatics. They're vessels essentially that parallel the blood vessels in the brain, but they contain a basically cerebrospinal fluid that seeps into them, but they also collect beta amyloid and clear it during the course of sleep. And glymphatics are not very active during wakefulness. This is extremely interesting. And if you don't clear beta amyloid from your brain properly, then it forms clumps or tangles, and that's one of the characteristic lesions of Alzheimer's disease. So we're beginning to shed light on an extremely exciting effect of sleep and how it can be used to prevent a certain kind of dementia. It's absolutely fascinating.
And not only the mechanism, but I've actually just looked at a couple of articles recently showing an actual correlation between sleep deprivation and the onset of dementia, although I don't know if it was clear that it was Alzheimer's per se. I also love the cleverness of physiology, the idea that adenosine is produced as you run down the batteries. Adenosine is dead batteries in the brain, and it
Right,
acts as a transmitter in the brain, a signal in the brain.
right.
And then
Mhm.
caffeine blocks the adenosine and hides that signal and keeps us awake longer. A lot of people may not realize that our brain is only about 2% of our body weight, but about 20% of our calorie usage. So, I
Mm.
mean, we're really burning those batteries. To me, it's just fascinating how indispensable sleep is. Look at the evolutionary cost of it, and we have to have it. So, why sleep doctors? Why is it a special branch of medicine?
Well, I wanted to mention a couple of other aspects of sleep and why it's important, besides the things we just talked about, if I could stray for a moment.
Mhm.
So it's been shown that there's evidence of heightened synthesis of proteins and tissue repair during sleep compared to during wakefulness. We talked about cognition. We talked about the lymphatics. Energy conservation is evolutionary in concept, in that you don't need to hunt and grow or whatever as many calories as you might need if you stayed awake 24/7. During the time that you sleep, your caloric expense is much lower. So sleep has that advantage. And then again, via uh, evolution, um, when you're asleep, you tend to be in a more protected environment, whether you're a day sleeper, like some rodents, for instance, or a night sleeper, like humans. You tend to be in a location that is safer from predators. And of course, that has a lot more to do with lower species lower on the evolutionary scale, probably, than us. But that's one of the ways that it is thought that sleep came to be. And finally, the kinds of sleep that we get, and there are actually two very distinct kinds of sleep, vary over the lifespan. So there's something called non-REM sleep, which is the kind of sleep that that consumes adenosine and restores our energy. And then there is something called rapid eye movement, or REM sleep. And the function of REM sleep is still somewhat unclear, although in adults it probably is one of the things that helps memory consolidation, but so does non-REM sleep. But in newborns, their sleep is about 50% rapid eye movement or REM sleep, which is far more than in an adult. In an adult, typically 20% of our night is spent in dreaming sleep. And what's interesting about dreaming sleep in newborns is that it's accompanied by a lot of twitching of muscle groups during the night. And one of the theories is that connections are being established between the nerves that go to those muscle groups and mapping them to parts of the brain that control them. And it's basically a way of brain maturation. And there are probably other aspects of dreaming sleep in newborns and infants that also help in brain maturation, because they just get so much dreaming sleep compared to adults.
Yeah, I've mulled over kind of a scenario in which a fiber optic splice could be put in over spinal damage, and a method rather like what newborns are doing to connect the neurons with the muscle fibers would help to connect the different ends of that splice so that they would find their correct signaling pathways. Um, you
That's
mentioned
what,
lymphatics, and I've
let
read.
me
So, go ahead. I'm sorry.
let me just extend that. There's something called post-polio syndrome that your listeners might be aware of, and it has to do with individuals who suffered from poliomyelitis, which is basically never seen anymore. but it causes paralysis of a variety of muscles depending upon its severity. And one of the muscles it can paralyze are the breathing muscles. And back in the 40s and 50s, people who had failure to be able to breathe because of that were put in iron lungs, which possibly some of the older members of your audience might be familiar with, but which went out of use in about the late 1950s. But those individuals who required an iron lung when they had polio, as they got older and older, their ventilation, their ability to breathe starts to fail. And the theory is that post-polio syndrome recapitulates the initial symptoms of their polio. And it does that because the way an individual recovers from polio, to the extent that they do, is that nerve fibers that before polio had the job of only stimulating a small amount of muscle tissue have now taken over a much larger number of muscle fibers. And over the years, that causes them to deteriorate. So post-polio syndrome, as I said, if the individual needed an iron lung when they had polio, they may need assistance in breathing when they develop post-polio syndrome. It's an extremely interesting topic, at least to me.
Yes. And it's interesting. So I swear to the audience, Lee and I did not rehearse this ahead of time, but that teed up my very next question, which is,
Right.
if we think about this function of REM sleep in helping babies connect the wiring between their brain and their body, do we know? So for the audience, after you have a stroke, depending on how bad the stroke is and some other things, your brain can learn to rewire itself in such a way that lost function can be restored. This is part of rehabilitation after a stroke. And it does it by redirecting circuits that already existed. If you've ever seen the Terminator movie where Arnold Schwarzenegger gets spiked through the head and it looks like he's dead, but then you see a little graphic where he rewires his brain and creates workarounds and he gets back in action. That was modeled on how we recover to the degree that we do from strokes. My question is, do we know whether increasing REM improves that stroke rehabilitation? And by the way, do we know how to increase REM?
So the answer to the first question is we don't know. We do know that patients who have had strokes, about 50% of them, if you've studied them in the sleep lab before their stroke, have obstructive sleep apnea. And if you study them after their stroke, at least 50% of them have obstructive sleep apnea. Of course, you don't know whether their sleep apnea predated or developed as a result of the stroke. Be that as it may, when you identify obstructive sleep apnea, which is a sleep disorder we could talk about if you'd like, in a post-stroke patient, and you get them on treatment for their obstructive sleep apnea as soon as possible, then their rehabilitation goes much more smoothly than if they have obstructive sleep apnea that's not treated. So sleep clearly has an effect on post-stroke rehabilitation. And in fact, we know it's been very well demonstrated that this disorder, obstructive sleep apnea, is far worse during REM sleep than it is during non-REM sleep. So you could hypothesize that if you're treating obstructive sleep apnea following a stroke so that an individual is able to achieve more REM sleep, then possibly that's the reason that their rehabilitation goes more smoothly. I can't say that for sure. There's a lot of additional research that needs to go into that, but it is one of the things that has face validity.
Well, it's interesting because usually the speculated the mechanism that people think it is that those neurons that are recoverable are more likely to recover if they get enough rest time, sleep time. But that would imply deep sleep would be doing more for us in stroke recovery than REM sleep. And I'm wondering whether fiddling with the ratio between deep and REM sleep might have implications for neurologic recovery. It's just an interesting question, and I don't know the answer, and maybe it's not known, but
It's not
intriguing
known.
area for you. What is new in sleep? So in your world, what are cutting edge things that people are looking at in sleep science?
Well, the glymphatic discovery is brand new, and it's one of the most exciting parts of sleep medicine as opposed to sleep practice. The different ways of treating sleep apnea, the different types of sleep apnea that sometimes require different modalities of treatment. I'm also quite interested in patients like post-polio patients, but also patients with Lou Gehrig's disease or multiple dystrophy or multiple sclerosis, who develop failure to breathe properly. One of my subspecialties, if you will, is how to breathe for them non-invasively, that is, with a nasal or an oronasal mask attached to a machine that helps them breathe. And there's some very, very advanced devices that are available, some of which I helped develop, that are now useful in that scenario. And in our sleep laboratory, we have great expertise in, during a night of testing in the sleep laboratory, monitoring carbon dioxide, which is the thing that when you breathe enough is normal in the blood. And if you don't breathe enough, it goes up in the blood. And we can adjust the settings on these devices while we monitor carbon dioxide and find just the right settings so that if they wear the device, it normalizes their breathing. I find that whole literature fascinating.
And I'll remind our listeners that you're an engineer as well. So when Dr. Brown says he helped develop these devices, he doesn't just mean he was a consulting physician. He means he helped develop these devices.
I guess I could say that. I partnered with the Mayo Clinic in Minnesota for the study that basically was the seminal study that got FDA approval for one of these devices, adaptive servo ventilation. So I didn't do the engineering part of it, but I understand the engineering part of it. And in fact, I've written 2 articles for the medical literature describing what's inside the black box of all of these devices, so that hopefully physicians know a little bit about what it is that they're treating patients with and why it may not be perfect and why they need to take into account the assumptions under which these devices work. It's not a simple matter. It's not cut and dried. And it's helpful for the clinician to understand that rather than just giving one of these to a patient, crossing your fingers and hope it works.
What should our listeners know, do you think, about the different kinds of sleep apnea? You mentioned there are different kinds, and I'm not sure everybody knows that. And I think it might be helpful to them if I were going to call up your office and make an appointment, or if I were wondering whether to worry about my sleep. What should I know about different kinds of sleep apnea?
Well, there are 2 major types, obstructive and central. Obstructive sleep apnea is the type that we see most often, and that is these are people who most often appear in a sleep disorders center. This comes about because something in the patient with this disorder causes their upper airway, the major entranceway into where air enters into the rest of the trachea and the lungs. This would be the back of the throat and down to where the tongue originates, which is called the base of tongue and is actually quite low down in the throat, believe it or not. Anyway, these individuals have some narrowing of that area, something that predisposes that area to be narrowed. Commonly, it's obesity, but also it has to do with the structure of the bones in the face, the size of the chin, whether the chin is small or recessed, and the shape and position of other tissues in the back of the throat, which is why obstructive sleep apnea tends to be inherited, by the way. But the fact is they have a predisposition to that airway being narrowed, and they depend upon a whole set of muscles that we call dilator muscles in that area to hold that passage open while they're awake so that they can breathe normally. The problem is when we fall asleep, in non-REM sleep and even more so in REM sleep, those muscles relax. And if they relax enough, then they impair airflow through that upper airway because it becomes narrow. Remember that that airway is depending upon those muscles to stay open during wakefulness. So during sleep, when those muscles relax, that airway may get narrow or close up entirely. The patient then struggles to breathe anywhere between 10 and 30 seconds typically, but I've seen it go on for more than 2 minutes. And eventually, the struggle to breathe wakes them up briefly. We call it an arousal rather than an awakening, because usually they don't remember it the next morning, but its purpose is to get those muscles working again. They open up the airway, the individual breathes really hard to catch up on their breathing, goes right back to sleep again and doesn't know it happened. And it's not unusual for us to see that occurring 50 to 100 times an hour in any given individual. And the result of that are manyfold. First of all, it causes sleep deprivation, as you might expect. So they end up being sleepy, and it's been demonstrated that about 50% of truck drivers, over-the-road truck drivers in America, have obstructive sleep apnea, probably because of their lifestyle. They eat a lot of fast food, and they're very sedentary, so they end up being overweight and prone to obstructive sleep apnea. But that's really scary because they're driving these 18-wheelers in a sleepy state. In addition to sleepiness, it's been shown that obstructive sleep apnea, when it's severe enough, leads to coronary artery disease and heart attacks, to heart failure, to high blood pressure, to diabetes, and to strokes and cerebrovascular disease. It has been connected to all of those things. And it's not that these individuals die in their sleep. That is an extremely rare thing to happen in obstructive sleep apnea, because our body is attuned to wake us up if we're having trouble breathing. But what happens over 10 or 20 or 30 years of having obstructive sleep apnea, it acts as a risk factor for all of these disorders that are serious that I mentioned. It's sort of like smoking. It's a risk factor, just like smoking.
Yeah, I tell my patients that it's comparable to hypertension as a risk factor. And part of the reason I wanted, and thank you for developing that question, I want listeners to understand that sleep apnea is not a minor medical condition. It absolutely needs to be evaluated and managed. And perhaps you could say a few words about when so I think a lot of people think not sleeping well at night is essentially a matter of comfort. And I'll cop to the fact that I did until I went to medical school. I would have regarded it as an uncomfortable inconvenience, but I wouldn't have thought of it as a medical problem. You see what I mean? So if people don't realize how serious this is, I can't fault them. I had to go and get some training before I knew it. So when should people say, you know what, I'm going to ask my doc for a referral? I mean, everybody has trouble sleeping once in a while. That probably doesn't merit a visit to you.
So we can get to the other kind of sleep apnea, essential sleep apnea, in a moment if you'd like. But as far as what are the symptoms that would suggest that somebody be referred to a sleep physician or a sleep disorders center. Excessive sleepiness would be first on my list. Loud snoring would be high up there. Witnessed cessations in breathing by a bed partner would be very high up on my list. That virtually guarantees an overnight sleep test looking for obstructive sleep apnea. Difficult to control high blood pressure. So if you need more than 2 drugs to control your blood pressure, that is in guidelines for blood pressure management as indicating the need for a sleep disorder center referral to see if you have obstructive sleep apnea. Waking up short of breath or gasping or choking or waking up with a snoring sensation, that would be high on the list as well. These are warning signs that you should ask for a referral for a sleep center evaluation. And then there are medical problems that occur that also are indications for referral. We talked about stroke already and how so many of these people have sleep apnea and they do better if it's diagnosed and treated. The same goes for heart failure. The same goes for a heart attack. All of these things are warning signs that you may have obstructive sleep apnea. And the problem is not everyone gets sleepy from having obstructive sleep apnea. Sleepiness from sleep deprivation is not just a matter of the accumulation of these chemicals that we talked about, but it's a trait. That is, some people are more resistant to sleep deprivation than others, which is why the amount of sleep that any individual requires to function the next day follows this bell-shaped curve, which is so common in biology. Yes, the average amount of sleep that an adult needs is 8 to 8.5 hours. But there are some people, and unfortunately I'm one of them, who need 9 or 9.5 hours. And there are some people who do just fine on 4 or 5 hours. And there are historical figures who reputedly got along on very little sleep. Leonardo da Vinci is often mentioned, as is Thomas Edison, although there's evidence that Thomas Edison took very short naps during the course of the day as he was working on his experiments or supervising them. But research has shown that when you sleep deprive somebody, some individuals will get sleepy the next day, and that's by objectively measuring their sleepiness with something called the multiple sleep latency test. And some people will do just fine. And if you repeat the experiment, the same thing will happen over and over again. So there are people that are resistant to sleep deprivation. And how much sleep do you need? Well, you can determine that yourself by seeing how much sleep you require in order to function well the next day and not be sleepy. And that's your target. That is your benchmark. That is the amount of sleep you should try to get. It's not rocket science. It's easy to determine. There's another aspect that I can't help but mention. And your audience may be aware that, and this originated from New York, where I came from, something called the Libby Zion case. There are now all kinds of rules as far as how much sleep you must allow trainees in medicine. These are trainees who are after medical school who go through residencies and fellowships. And this is of particular concern in surgery. In surgery, there used to be a triangle. A lot of people would enter the first year of a surgical residency, and not a lot of them would emerge as graduates of the program. And my thesis is that the ones who successfully graduated are the ones who were more resistant to the sleep deprivation that is part and parcel of being a surgeon. And now that no longer happens. Their hours are restricted. They don't get sleep deprivation anymore. And I, frankly, am worried that we're developing a whole group of surgeons and OBGYNs and neurosurgeons who, when they go out and practice, there are no restrictions on their working hours and how much sleep they may get. And I worry that people who are less resistant to sleep deprivation may be out there practicing, and that would be the detriment of their patients. That's what I say on my soapbox.
Now that's interesting because the rule limiting how much we can work residents came into place the year after I finished my residency.
No, poor thing.
But I actually favor it, so I'll make a case for it. Well, a case for it and against it. This is actually, I think, of relevance to the general public because you're going to be treated by these people, right? So
Right.
some data seem to show that significantly more errors were made when residents were further from their last sleep cycle. And you'd predict that. That makes all kinds of sense. So it didn't surprise anybody. That was the primary argument for limiting the hours to 80 a week, because it used to be almost double that when Lee and I were residents, for example.
Mm-hmm.
And, you hear that and you think, can that possibly be true? Frankly, I didn't believe it was true when I started residency. I thought it was an exaggeration. Nope, it was actually true. And it seemed like a bad idea. And remember, this is a period of learning, and sleep is important for consolidating long-term memory. So it makes sense to me as an educator. Lee's other hat is engineer, my other hat is educator. And from that standpoint, it makes sense to me that you would protect sleep. I always tell my students, don't skip sleep in the name of homework, for example. But it has not been shown that the error rate decreased when the hours were managed. And that's very counterintuitive. And it means that the primary benefit we're looking for didn't happen. I still think it's humane. And I think from a learning standpoint, it's a good idea to limit hours. Now, one problem may be the hours look limited, but they're not, because they work you like a dog for 80 hours. And then you go home and study and so forth, right? And so you're still putting in the same number of hours, but it's not all on the clock. I think maybe the reason that we didn't get the benefit that we were looking for. It's an interesting area, and it's not yet settled what is the optimum way to train physicians. And I think it's refreshingly that you make a pitch for the older system, because I have not heard that argument made before, and I like to hear two sides of an idea.
I've actually wrote about it in commentaries. I can send you one if you'd like.
Yeah,
you're right. And you're right. The literature by the major proponents, the people who have bought this hook, line, and sinker, and who were the people responsible for the work hours limitations, have done extensive research looking for a positive result from limiting work hours for trainees. And by and large, they have not found that in mortality or in mistakes or in any other outcome measure you care to name. Now, you're right. You may limit hours in the hospital or in the clinic for trainees, but you have no control over what they do when they go home. I would like to think that they're studying, and you obviously would like to think that also. But I know a lot of our trainees, mostly fellows, who moonlight, and they work at a variety of hospitals.
As I did.
Doing clinical work when they're not required to be on duty in the hospital or the clinic where they're training. And then, there are parties. Well, of course, that was pre-COVID, but there are all kinds of other activities, binge watching, I don't know, Law and Order or whatever
Wouldn't it be hilarious if we actually did them a favor by limiting their free time, by preventing them from partying and watching TV? We help their training.
let me know my idea. And my idea, well, I have two ideas, actually. One idea is that when they report for clinical duty, they should do one of these computerized reaction tests to see if they are impaired due to sleepiness. You can also detect sleepiness non-invasively. Mercedes-Benz has been very strong in this regard. They've developed a number of ways that other automakers have since adopted to try to detect the sleepy driver and wake them up by shaking the steering wheel, for instance. These are the same ways, to an extent, that we could detect sleepiness in a trainee or a grown-up physician and say maybe they should go take a nap.
Yeah, we could use that eye tracking technology, for example, on surgeons and tell a surgeon when it's time to let a relief step in or something like that.
Right.
That'd be
Well, one thing is if their eyes are closing a lot. Another thing is pupillary instability. When you are sleepy, your pupils change diameter, indicating your sleepiness. The diameter is more stable, assuming you're focusing on the same thing and the light hasn't changed when you're alert. But your pupil diameter is unstable when you're sleepy. And there are ways of non-invasively measuring pupillary diameter. The ideas are endless. It just takes actually putting them into effect. And then the final piece of it that I'm particularly interested in because of my most recent work is the alerting effects of bright blue light. So first of all, if you can detect that somebody is sleepy, you can shine bright blue light on them, and that has an alerting effect.
So truck dashboards might have blue lights in them, for example.
Well, they could. That might be an interesting idea. Military planes, at least they used to, routinely had red colored indicators. And don't you fly? I think you're a pilot.
No, I'm not a pilot, but that was
So-
to protect night vision.
Exactly. But it does exactly the opposite as far as maintaining wakefulness. So one wonders about the trade-off there. But my other idea is that you should be able to control the lighting in clinical areas. The lighting in patients' rooms should be controlled so that it strengthens their ability to sleep at night by limiting bright blue light. But probably the light in the other areas, the hallways and the nurses' stations and whatever, the workrooms, should be very bright and tend towards the blue. And I was asked to help in the design of lighting in the new tower that's being constructed by UNM. And I hope they took what I advised them to heart, even though it does add expense to constructing a clinical facility. But there are ways to optimize various things, patient sleep and clinician alertness, nurses alertness, by controlling the lighting. It's very, very important.
Yeah, and you might want it different in areas like the waiting room where you'd like people to relax, and areas that are working areas where you want everybody alert. I mean, there's ways to take advantage of that.
That's exactly true.
I have another question for you, Lee. I've become aware that our brain gains in volume at night when we sleep. I don't want to say brain swelling because that sounds pathological, that it normally gains a bit of volume when we sleep at night. And I believe this is associated with the glymphatics, which I think is a portmanteau of the glial system and the lymphatic system. Where I'm going with this is, does this have any implications for the best position for sleeping? You mentioned the soft tissue in the throat. Many sources recommend sleeping on your back, but for sleep apnea, would that be ideal? Or does it help people to have their head upward? Does that help with both issues? Do we care about the brain volume at night? So what about position in sleeping? What do you have any special recommendations?
Well, it's been known for a very long time that people who are prone to having obstructive sleep apnea will have it to a more severe degree when they sleep on their back. And that has to do with gravity allowing the tongue and the base of the tongue to fall backwards and compromise the upper airway, which is why I have obstructive sleep apnea. And for years, every time I tried to sleep on my back, I would wake up snoring with a snore. And my wife would complain about my snoring constantly, shall I say. And eventually, when we opened a new sleep laboratory, I volunteered to test out the equipment. And lo and behold, I had severe obstructive sleep apnea. That was about 8 years ago. And since then, I've been a very loyal user of CPAP, and it has made a big difference in my life. And I can sleep on my back if I want to, although I prefer to sleep on my side. I probably learned to sleep on my side because of my sleep apnea. But sleeping on your back is anathema to people who have or tend to have obstructive sleep apnea. As far as the brain volume is concerned, well, during sleep is when the lymphatics have contents in them and are flowing. During wakefulness, the actions of the lymphatics have been shown to be highly attenuated. I don't know whether the two are connected, but the other finding that is well established is that when you are reclining, which is the position most people sleep in, whether it's supine, right or left side, or on their tummies, the fluid that collects in their legs during the course of the day travels upward towards the torso and on towards the upper airway and presumably into the brain.
Yeah, gravity doesn't drain it.
I'm sorry?
Gravity doesn't drain it. Gravity isn't working for us.
Yeah, well, exactly. And so you can demonstrate, for instance, that people who have obstructive sleep apnea, it's more severe towards the end of the night, not just because they have more dreaming sleep towards the end of the night, but because there is this shift in fluid upward, and their neck circumference goes up, and you can show that their breathing passage becomes more narrow because it is more edematous. There's more fluid in it. That's even more true in people who have congestive heart failure or kidney failure, who tend to be fluid overloaded to begin with. The effects of that posture are even more prominent in those individuals, but it happens to all of us, actually.
So, well, okay, so I'll just say, because I want people to have a takeaway they can use tomorrow. What general recommendations do you have for people without a medical condition to sleep better? What should most of us know that we're not doing?
Well, there's such a thing called sleep hygiene. In fact, it's an official international classification of sleep disorders, 3rd edition diagnosis, which is called inadequate sleep hygiene. And it has to do with not keeping to a regular time of awakening, and similarly not keeping to a regular bedtime, and trying to sleep the same number of hours every day. And that strengthens what's called our circadian rhythm, which has to do with a clock in our brain that controls a wakefulness drive. And regular bedtimes and regular times of awakening, in addition to bright light in the morning, are 3 of the most important things to keep that clock running on time. Other things having to do with sleep hygiene, the most important thing these days is watching television or using a personal computing device before you go to bed. All of these devices
are things you should not do because of the blue light.
Exactly. That's exactly what I was leading to. And you can use them if you want, but you need to download an application. They are free. There's one called F-Lux that knows what time it is because your smartphone knows what time it is, and it starts removing blue light from the display as it comes towards the evening. And then you can also purchase, the internet, you can find anything. You can purchase filters that you can place over your television screen that filter out blue light so that there's less of an effect. If you insist on watching TV or using your smartphone in bed, you can do something to ameliorate the problem by limiting the amount of blue light that you're exposed to. Of course, it's better not to do it at all.
No, I find that I occasionally have a pattern of going to bed later and later. And when I notice that occurring, I'll use melatonin and go to bed at a regular time in an effort to reset my clock. Is that a reasonable strategy, or am I just wasting money?
No, it's actually an accepted part of sleep medicine practice. Melatonin level is quite low throughout the day. And when you are in dim light, the pineal gland, which in some creatures is actually light sensitive, but in humans reacts to light striking a set of light sensitive cells behind the retina. The pineal gland secretes melatonin. And melatonin is one of the things that tells your clock, your brain clock, that it's time to start getting sleepy. And the melatonin level stays relatively high throughout the night. And then as soon as there's light out, it drops to almost nothing. And so taking melatonin, and it's only a small dose, 0.5 to 1 milligram, 1 to 1.5 hours before bedtime, can strengthen a normal circadian rhythm. And it is something that we do recommend to our patients. The problem is that when you buy it over the counter in one of the commercial pharmacies as a nutritional supplement, you actually don't know whether it has melatonin in it at all. And you don't know how much is in it, because that's been studied both by Consumer Reports or Consumers Union and by medical researchers. And so when we prescribe melatonin for our patients, there are two pharmacies in our city who are compounding pharmacies and who will take pure melatonin and put it in a capsule at whatever dose you specify and dispense it to the patient, so they're getting melatonin rather than whatever is in the thing they buy over in the pharmacy.
So assuming you're getting what the label says you're getting, which is, we know, not necessarily true, it's 0.5 milligram to 1 milligram, you're saying?
So that's the dose to strengthen the internal clock in the brain. Mm-hmm. Then melatonin does have hypnotic, sleep-inducing properties at higher doses, and somewhere between 3 to 9 milligrams can commonly be used as a way of helping people fall asleep. It's not a bulletproof method. Its efficacy varies, but it's a very safe medication, much safer than even the safest sleeping pill. So it's always in our practice worth a try if we have a patient with sleep onset insomnia and we want to try something that is quite safe and see if it does the job and helps them sleep. And of course, it already has at least 0.5 to 1 milligram in it, so it also strengthens circadian rhythm. There are new formulations that unfortunately are only over the counter that are sustained release melatonin. They have a pretty good reputation, although I don't know that anyone has studied what's in them. But they give a burst of melatonin at first, and then maintain a sustained level of melatonin during most of the night. The way melatonin normally acts in a normal sleeper. And so it's not unusual that we will suggest somebody who has sleep onset and maintenance insomnia that they try a sustained release formulation of melatonin to see if they are able to have more consolidated sleep with fewer awakenings.
This is a good time to check in with you, Lee. We've used a good chunk of your time tonight, which I have time, but I know that you have lots of obligations. We promised we wouldn't go long, and I think we have a bit already. Are you okay with time?
I'm okay. I can talk about sleep 24/7, 365.
All right.
I consider myself a second generation sleep physician. So I was taught by the first generation who came into sleep medicine and invented the specialty in the 60s and early 70s. People like Mary Carskadden and Bill Dement. I was taught by some of them and some of their first generation colleagues sleep medicine, and therefore I consider myself in the second generation of sleep medicine specialists. I've been at this for 40 years. And back in the beginning, sleep and studying sleep disorders was looked upon by the rest of the medical community as something, excuse me, something peculiar, as why would you want to study sleep? Nothing happens during sleep. It's not worth studying. And I was even told that by the chair of neurology at Mount Sinai Medical Center, Mount Sinai Hospital, where I trained in medicine as a medical student and a resident, and later was a faculty member. When I tried to start a sleep medicine program at Mount Sinai, and this had to be back in around 1982, 1983, Melvin Yar, the chair of neurology, who was an extremely famous neurologist and an expert in Parkinson's disease and movement disorders, I sat down in front of him and said, we need to study this in patients with neurologic disease. And he said, studying sleep will come to nothing. It's not worth doing, and I won't support it. Well, that's the kind of reaction those of us in the first few generations of sleep practice had. And because of that, we've developed a camaraderie. We consider sleep medicine, clinical sleep, almost a calling. In fact, it is a calling. And my board certification in sleep medicine bears the number just over 600. So at the time I qualified as a board certified sleep physician, there were only 600 or 700 of us in the entire country at the time. It was a niche. It was not very well respected. One of the extremely smart internists at Mount Sinai once called sleep apnea, obstructive sleep apnea, an epidemic that is spread by physicians. And those of us who took on sleep as a calling, we try to impart that same feeling to our trainees. And that's something I've done for 40 years, for my entire career.
Well, there's been an explosion of research into sleep in the period since then. And I think I speak for other physicians in saying that the medical importance of sleep is no longer controversial. I think we recognize this as a very fundamental aspect of medical health. I will say that, so bear in mind, my area I'm not a sleep specialist. I'm an emergency medicine physician. But when people come to the emergency room complaining about sleep-related disorders, they are furious at me if I try to talk to them about sleep hygiene. I went to a lot of trouble to learn what I could about, I mean, I'm not at your level, but I knew all the recommendations for sleep hygiene as currently as I was able to, and made referrals to the sleep clinic. And that is not what they want. What they want is pills. And of course, a lot of people use alcohol and believe that it helps with their sleep. So this might be a good time to talk about the role of medications, including over-the-counter home remedies for insomnia and the pros and cons of those.
Well, you're right that a lot of patients who come to us complaining of insomnia expect us to prescribe a medication to make them sleep. Unfortunately, these medications are FDA approved, and there are quite a variety of them, and they all work in different ways. Well, many of them work in similar ways, and a few of them work in different ways. But they all have one thing in common when they're tested for FDA approval, and that is that by and large, they decrease the time it takes to fall asleep only by an average of about 20 minutes. So they're no panacea. They can be helpful, but you're not going to be able to take one of these and fall asleep in 2 minutes unless you overdose on it. It can be helpful, but not as helpful as people think. And some of them do have side effects. Some of them in particular will make obstructive sleep apnea worse, for instance.
I was just going to ask about that. I worry that people with sleep apnea
Yeah.
will take a drug that lets them sleep better, but because they're not waking up and breathing like they need to, which is a bad trait, I presume.
Yeah, and there's another thing that general practice physicians are guilty of that I rail against, and that is if somebody complains of having obstructive sleep apnea or they have an overnight oxygen recording that shows dips that may be due to sleep apnea, before they get to the sleep lab, they get put on oxygen. And oxygen commonly prolongs obstructive sleep apnea events because it lengthens the time before the drive to try to breathe is strong enough to wake somebody up when their breathing is obstructed.
Which allows their carbon dioxide to go up, which changes their pH, their acid-base balance, and damages their metabolism. So
Yes, that's
yeah, people need
exactly
to know
true.
this stuff.
So you can make your oxygen normal, but you're really not doing them any favor. What you want to do is diagnose and treat their obstructive sleep apnea and provide this positive airway pressure treatment that stents open the upper airway and prevents obstructive apneas and hypopneas from occurring.
But now imagine that you're the other Dr. Brown, the good-looking one, working in the emergency
that was
room.
me.
Working in the emergency room.
That's what Mom always said.
Your colleagues are furious at you if you take the time to teach sleep hygiene. The patient is furious at you if you're not writing a prescription. You're being measured by how many bodies per hour you see. And there's somebody in the waiting room who might be sicker than the one I'm seeing right now complaining of insomnia. What do I do about the pressure to just go ahead and write a sleep medicine?
So there are two aspects of that I'd like to talk about. One is that I very rarely come up against a patient who is angry that I'm not prescribing a hypnotic, a sleeping pill. When I go through the details of what they're doing that is preventing them from sleeping well, most of them understand it. People who didn't even finish high school, all the way certainly up to people who work at Los Alamos or Sandia Labs, they all really understand it. And they're willing to give sleep hygiene and the main treatment for insomnia, which is cognitive behavioral therapy for insomnia, a try. My telephone is ringing, but it's the line that we never answer. So I hope it isn't too disruptive. It will stop in a minute. So I don't really come up against very much resistance. And luckily for my time, there are very good internet-based programs that do this cognitive behavioral therapy for insomnia that I can tell people about. And they've all been studied in research. One of them came out of Harvard, for instance, and I have a list of them that I give to patients. And many of them don't need to come back because they've gone through internet-based cognitive behavioral therapy, and they do just fine. Okay.
So I recall, Lee, that among your papers was one that dealt with cognitive behavioral therapy programs for sleep hygiene. At the moment, neither of us can remember specifically what I'm referring to, but you know, it's an area you've done some work, some research into.
Well, I am
The other one, though, go ahead.
I'm 71 years old, so it's possible I wrote one and don't remember.
Well,
But
you've written a lot of papers. I bet you don't remember them all off the top of your head. I'm impressed.
yeah, a lot of them I don't remember the details of, at least, but I like to see them on my CV. What I did do is review a book that you mentioned, which was published by Larry Epstein, who is a close colleague, who, when he was at Harvard, he may still be at Harvard, I'm not sure, wrote a book about sleep. And I reviewed it because at the time I was the book review editor for one of the journals that covered pulmonary critical care and sleep medicine. I was the book review editor, and this was a paper. It was written by a friend of mine, and it was an interesting subject, so I took it on as my own review. And a lot of it, indeed, had to do with sleep hygiene and cognitive behavioral therapy for insomnia. And so, of course, that sort of information is in the text of my book review. So to that extent, I do remember writing something about it. I've certainly spoken about it at professional meetings. And, you know, as a pulmonologist who does sleep, when you see your clinic patient list and one of them has a chief complaint of insomnia, internally you shudder a little, because it's not going to be a straightforward obstructive sleep apnea, which is much easier to handle in clinic. But when you devote yourself to sleep medicine, you take on the responsibility of treating insomnia with the same zeal as respiratory disorders in sleep, which of course is more of interest to a pulmonologist. And so I don't know what I was getting at that, but so I was assigned in a session, a postgraduate course actually, an update on sleep medicine, to talk about the latest research in insomnia, which I wasn't too excited about, but it was actually a fascinating exercise in looking through the recent literature in insomnia and speaking about it to a national and international audience of physicians. So internally, it may mean more work for me, but internally also, I know it's extremely important, and I know the literature and I know what to do. And so I take it very seriously, and I take it very seriously with my patient. And I think they appreciate that. And that may be why they understand the things I tell them, and understand why I don't just give them a sleeping pill, because I impart to them the things that are well researched that can help insomnia. And I impart to them the downside of taking sleeping pills. And you'd be surprised how many people there are out there who actually don't like taking medications. And even if you prescribe one, they're anxious to get off it, even if it's for not insomnia, but for restless leg syndrome or a variety of other sleep disorders that respond to medications that are not sleeping pills. People don't like polypharmacy, a lot of folks. And so it isn't as hard as you might expect. Maybe in the ED it is, but in an outpatient sleep practice, it turns out not to be so bad.
And I'll mention for our listeners that Dr. Brown actually went to the trouble of running some paragraphs through a computer diagnostic. And this book, The Harvard Medical School Guide to a Good Night's Sleep, would be readable by a sophomore in high school. So it's written by national experts. but it's intended for lay people. In fact, that's the same audience we're hoping this podcast will reach. People
Yeah.
who don't want their information thinned down, but who don't necessarily have a professional education in the area.
Yeah, much to Larry Epstein's delight. I gave it a great review, and I touted it as being written at a level that people would understand.
Yep.
He did a great job.
All right. What did we not ask you that you were hoping we would touch on tonight, Lee?
Well, we didn't talk about the other kind of sleep apnea, central sleep apnea. We didn't talk about restless leg syndrome, which we can cover if you'd like. But the other kind of sleep apnea is central sleep apnea. And this is where the brain fails to tell the breathing muscles to breathe for a period of time. And there are two main categories. One type is called hypoventilatory central sleep apnea. And these are people who are taking medications that suppress the drive to breathe in the brain.
Like alcohol, for example?
Well, by and large, they're opioids. And it also includes what are called gabapentinoids. Pregabalin or Lyrica, I don't know if I'm supposed to give trade names, but is a gabapentinoid. There are multiple formulations of gabapentin, and it's been shown that if somebody on the outside is abusing an opioid and also takes a gabapentinoid, that the likelihood that they will OD and die is higher because the gabapentinoid interacts with the opioid to cause more respiratory depression. And in fact,
I'm going to pause there for a moment and repeat
Sure.
that, because this is a point that shows up in the emergency room a lot. This is really important for lay people to understand. Everything you take that can sedate you can interfere with your breathing. And all of them can not just add to each other, but multiply with each other. So a few Valium will, in someone like me, would not represent any risk that I'd stop breathing. A few beers would not represent any risk that I'd stop breathing. But a very safe dose of Valium plus a very safe dose of beer could be suicide, right? Could it literally kill me? So when you start adding sleep medications together, and that includes over-the-counter and alcohol, you risk sleeping forever. Okay. And I make that sound like it might be a gentle way of self-euthanasia. It's actually a pretty miserable way to go. It would be like having somebody put a pillow over your face. So don't use sedatives that aren't prescribed. Make sure that if somebody is prescribing sedatives, they know what else you're taking. Don't doctor shop, don't mix prescriptions. And I'm going to go all Nancy Reagan here for a minute and say, don't use drugs, because they can freaking kill you. And the reason I'm making such a point of this is that I'm the guy your body will be brought to, and I don't want to see you that way.
So at the risk of our imaginary mutual mother objecting.
The one who says you have 3 licenses, 3, and I only have 1. She's like, why can't you be like your brother? You just went to medical school. Why can't you be like Lee? I'm like, Mom, most people would say that was okay.
I'm Jewish, and there's a saying, a joke out there that a fetus doesn't become a human being until it graduates from medical school. Besides that, I would take issue with over-the-counter sleeping medications. By and large, they're all antihistamines, first-generation antihistamines that make you sleepy but don't impair your breathing. They do, however, pose a risk in some people that may make it dicey for them to take it. So most of them have what's called an anticholinergic property. And so older men who have prostate problems may have more trouble urinating if they take an over-the-counter sleeping pill with a first-generation antihistamine in it. They can worsen this disorder, restless leg syndrome, that I mentioned, especially in children who can get RLS. And there's some evidence that the sleepiness that they induce in an unsupervised environment can lead to more falls in the elderly. So those are sort of the downsides of the over-the-counter sleeping pills. There's not much else to say you shouldn't use them. Well, they also cause dry mouth sometimes, but otherwise, I have patients who come to me who are taking one of these, and they tell me that it's working great for them, and I don't see any reason to stop it, frankly, because the alternatives are prescription medications that may not work any better, and if they're tolerating the over-the-counter med, I have no problem with it. And then there are a bunch of other medications that we prescribe to help sleep that are psychiatric medications that a side effect of them is sleepiness, and they also don't impair ventilatory drive. So those are safe too, and there's no interaction with sleeping pills. But then you touch upon alcohol, and that's an extremely important subject. So you're right, the combination of alcohol and a real sleeping pill is not a good one. And a combination of alcohol and an opioid, or alcohol and an opioid and a gabapentinoid, is a recipe for showing up in the ED and maybe not leaving. The other downside of alcohol, when it's used by someone as a way of inducing sleep, is that it's a very short-acting sleeping medication. It makes you sleepy initially, but by a couple of hours into the night, maybe halfway into the night, the level is so low that you begin to withdraw from the effects of alcohol. And the withdrawal effect is actually activating. It prevents good sleep. So using alcohol as a hypnotic, a sleeping pill, is a losing proposition. The other bad thing about alcohol is if you have obstructive sleep apnea, it definitely makes it worse. And so we tell people at the end of every visit, don't drink alcohol within 4 hours of bedtime. And if you do, make sure you use your CPAP, because alcohol is going to make it worse. And that was actually demonstrated way back when I was a pulmonary and critical care fellow in a program that had one of the first sleep programs in the country. And they did research showing that alcohol intake worsened obstructive sleep apnea and snoring. And any wife can tell you that, or any spouse, or any bed partner, that if your bed partner drinks alcohol, you're not going to sleep well because he or she is going to be snoring.
Now, if you guys are going to look up sleep hygiene, we've mentioned it several times now, and I recommend that you do learn about sleep hygiene. It's probably a little beyond our scope tonight, but go to a site like Harvard Medical School, or at least a medical school, or go to a academic sleep medicine site, or go to Mayo Clinic. They have a lot of good patient guides there.
Yes.
Or Medscape. Do not go to Twitter and Facebook and Gwyneth Paltrow. That is not where you should go for medical advice.
That is exactly true. I can't say that enough, that there are a lot of myths out there, just like there are a lot of political things that are going on, and things about the COVID vaccines that are just not true. You need to take your advice about sleep from somebody who knows what they're talking about, or from an institution that properly vets the information on their site, and you can depend upon the information that you get from them.
I'm a physician, and I'm not qualified to be your coach on this. You need to go to a sleep doctor,
Right.
Or a sleep doctor site for general sleep hygiene, which is a do-it-yourself-at-home thing. If that doesn't work, then you're probably going to need a consultation.
I will say, and this is the sad part of having been a sleep physician for 40 years, and that is, sleep started out as this niche that people were suspicious about and didn't quite seem to have any relevance or any worth. And then it became a very important subject, and it became the subject of fellowships, and it became an American Board of Medical Specialties certified specialty. And things were going really great in making sleep a bona fide and worthwhile type of medical care to pursue and type of research. Then it started a decline. And the first thing that happened was that Medicare approved the use of home sleep apnea tests, which have their place, but also are not useful in many situations. But they're a lot cheaper. In fact, the reimbursement for a home sleep apnea test doesn't even pay for the time it takes to do it and the supplies it takes to perform it and the equipment that is used to do it. And virtually all the insurers prefer that home sleep apnea tests be done, and it has become very hard to get a laboratory sleep study approved. I spend a lot of time on the phone doing appeals to get pre-authorizations for laboratory studies that are absolutely necessary for a patient. The fact that home sleep apnea testing has become so ubiquitous and pays so little means that sleep disorders centers, which used to be cash cows, get my both fingers in there, cash cows, no longer are. Our academic sleep center at UNM loses money every year, and it's never going to make money if it continues being an academic, very highly professional, highly skilled sleep practice. And that's a fight we're having right now. And if there's anyone in the audience who has anything to say about how the University of New Mexico is failing to support sleep medicine at UNM, we sure could use some help right now, because it may just go away at UNM. And I'm quite serious, because it is not a cash cow. It loses money, but so do a lot of parts of medicine that are supported. Infectious disease, for instance, costs a huge amount of money to the system, but doesn't make a dime. It costs the system money, but it is absolutely necessary in a tertiary and quaternary care medical center, such as University Hospital in Albuquerque. And so too is academic sleep medicine. It may not pay for itself, but you got to have it if you claim to be a prestigious academic medical center. That's my soapbox for the night.
Yeah, everything that's important isn't lucrative, and everything that's lucrative isn't important.
That's true.
All that said, we probably have more than we can edit into a single show tonight. So this is probably a good place to stop. But
Sure.
clearly, there's a lot more we could talk about. I really hope, Lee, that we'll get a chance to enjoy your company again. I really appreciate Toby and Shelley for setting this up. I greatly appreciate you. I know I'm well aware of how busy you are, and I appreciate you taking time for us tonight. I hope this really helps some people in the community. And we will be back Monday, June 7th. I'd tell you who we're going to have, but there's 2 or 3 people I'm talking to at the moment, so I don't know yet. But luckily for all of us, I know some super interesting people through my career. So I have some excellent content.
I know some pretty boring ones too, but I won't mention them.
But we'll try not to bring them up.
But as I mentioned, I could talk about sleep 24/7, 365. So what I can say about sleep is virtually without end. And I hope your audience enjoys what we've talked about. And I hope to be with you again. I enjoyed it.
I hope I said June 7th, by the way, rather than July 7th. Lee, I hope to see you again another time. So block us out in your calendar, and we'll do this again in the future. Thank you again so much.
You are very welcome. It's been my pleasure.
What's New in Health and Medicine with Dr. Coffee Brown, video and podcast, is produced by Shelley Carney and Toby Eunice from the AGK Media LLC online studio. Please take a moment now to subscribe and leave a great review. Then share this podcast with your family and friends so they can improve their health too. Thanks for listening.